Dr. N. Mukherjee sir, Dr. K. K. Mukhopadhyay sir, and Dr. Rajeev Raman sir, welcome. Also, we extend our gratitude to each one of you. I think all the delegates who are sitting for the meeting, we welcome you all. And also a special acknowledgement to our delegates who are joining from the remote locations. Uh, I think as we recently celebrated Shubha Navavarsho, so I think I would like to take this opportunity to wish you a very prosperous and healthy new year. With that, I think we can now invite all the esteemed doctors, all the chairpersons to join us for the lamp lighting ceremony, marking the beginning of this enlightened session ahead. If we can just start with the lamp lighting ceremony. Yeah.
या निशेष जाड्या
Good evening, distinguished guests. I am Dr. Atul Sharma. I am part of the medical affairs at HALEON. It's both my pleasure and an honor to welcome you all to this joint and mobility conclave being run by HALEON. As we gather today to share knowledge, learning, spark new ideas, explore frontiers of science, it's only fitting that we begin by introducing the prestigious panel of chairperson and the speaker for today's event. So I begin with a short introduction, although Dr. Ananda Kishore Pal needs no introduction. Dr. Professor, Head of the Department of Orthopaedics, Government Medical College, Jalpaiguri. Ex-President, ex-Vice President, West Bengal Orthopaedic Association, a mentor, a guide for all, an inspiration to follow for all upcoming orthopedic surgeons. Sir, may I invite you to the dais. Next, I introduce Dr. Kiran Kumar Mukhopadhyay, Professor, NRS Medical College and Hospital, Kolkata, Consultant and Spine Surgeon, Genesis Hospital, a senior expert, a teacher, pivotal in shaping the next generation of clinicians. Sir, may I invite you to the dais. Dr. Amitava Narayan Mukherjee, Chief Orthopedic and Joint Replacement Surgeon, Ortho and Joint Replacement Clinic, Kolkata, a highly experienced professional and a guide with strong focus on innovation and research. Dr. Mukherjee, please. Dr. Rajeev Raman, Additional Professor, GIS School of Medicine, Consultant Orthopedic Surgeon, AMRI Hospital, Joint and Bone Care Hospital, Salt Lake, Kolkata, Senior Expert with vast clinical acumen and deep commitment to patient-centric care. And let me introduce now to our distinguished international speaker, Dr. Nancy E. Lane, Professor of Medicine and Rheumatology, UC Davis School of Medicine, Sacramento, California, Adjunct Professor of Medicine and Rheumatology, Stanford Medical School. Thank you so much to all our experts. Before I invite Dr. Nancy for her talk, I have some introduction slide to give an overview of OA, osteoarthritis in India. So I'll just share some data point before we hear from the distinguished international speaker. So you may sit here or yeah, whatever. Yeah, sir. Yeah, we'll invite you again. Yeah, again. Yeah. Maybe we'll invite you back so that you can also see the presentation on the larger screen. Okay. So this is the outline that I intend to highlight today. So what about the burden of OA? This is coming from the last 3 decades at a glance. So globally, 395 million sufferers of OA, which has increased over the last 3 decades by 132.2%, accounting from 1990 to 2020, which is further projected to increase by 74% for knee, 48% for hand, 78% for hip, and 95% for other types of OA by 2050. So if you account for adults age more than equal to 70 years, OA is ranked as the 7th most common cause for years lived with disability globally. So it affects, all geographies with varied prevalence, from some countries having higher prevalence than others. Now, what about India? So in India, OA affects 22 to 39% of Indian population and is a serious public health concern. So burden increased from 23.4 million to around 62.3 million in last 3 decades, accounting for years 1990 to 2019. And the prevalence trend is only on the rise. If you see severity of OA, so 47% of Indians have mild OA, 35.9% have moderate, and 17.1% have severe OA. So the prevalence is higher among women than men, which we know. Approximately 40% of population more than 70 years show OA, in which nearly 2% have severe pain and disability. Incidence of knee OA increases tenfold amongst ages of 30 and 65 years. And we know the contributing factor, which be obesity, increase in age, gender, which is, women more than men, and some association with education background, occupation as the defined risk factors. Now, what is the burden of this disability? So it impacts, economic burden on various aspects, which include direct, indirect, and intangible. So from direct, direct costs include pharmacological treatment cost, surgery, adverse event associated with drug use, long-term care, healthcare provisions. Intangible costs includes, pain, limitation in activity, reduction in quality of life, fatigue, reduction in social interactions. Indirect cost include absenteeism, reduced employment, reduced productivity, caregiver time, and premature mortality. So based on some estimate, if you see the cost of OA in India, which include direct and indirect, for medical management of knee OA, it is reported somewhere around 20,000 rupees, whereas surgical cost, although there is no defined data, but it is estimated to be, from 1 to 5 lakhs for TKA, total knee associated surgeries. Now, if you look at the management options, so management strategy primarily revolves around reducing pain and discomfort of the sufferers, maintaining joint stability, and avoiding functional loss. So the management option include pharmacological, which are primarily NSAIDs, COX-2 inhibitors, intra-articular injections, corticosteroids, hyaluronic acid, interleukins, and stem cells. There are some alternative therapies, more so in India, wherein Ayurveda and homeopathy coming into play. Then the newer options from food supplement like chondroitin, omega vitamins, glucosamine, and UC2. Non-pharmacological management, including physiotherapy, knee brace, knee caliper, etc. Then, of course, surgical therapy for late OA, which is total partial knee replacement, cartilage graft, arthrotomy, chondrotomy, etc. And then herbal, which are also part of the Ayurvedic scheme of things, which include boswellia, somnifera, Vethenia somnifera, Amblica ossifalis, etc. And then there are certain futuristic approaches which include laser-assisted chondrogenesis, matrix-induced chondrogenesis, etc. Now, looking at these options, what are various guidelines, globally available, and how do they place various options that we have in terms of their evidence in management of osteoarthritis? So those highlighted in bold, remains cornerstone across various guidelines available. So basically, this pins down to oral NSAIDs, topical NSAID, and intra-articular corticosteroids. Other options, are recommended by some and not so recommended by other guidelines. So acetaminophen, or paracetamol less than 4 grams is, recommended by majority of guidelines, whereas capsaicin not so, glucosamine, chondroitin of late, again, even including in India now, the combination at least is not recognized anymore by by DCGI. And the other modalities, so not accepted across as a universal for management of OA. Well, there are newer trends which are coming up. So this is coming up from the recent publication from IORA, wherein newer modalities like UC2, Undenatured Collagen 2, along with paracetamol, has been included in the step-up approach in the management of OA, along with other non-steroidal anti-inflammatory drug, COX-2 inhibitor, etc. So this gives a detailed, step-up approach in management of OA. So these are the newer trends, newer evidence which is being generated globally and accepted across various geographies from, some extent to varied extent from, being it included in guideline and some still exploring it on the available evidence. So what is UC2? So UC2 is undenatured collagen 2. It has unique collagen structure, and Dr. Nancy is the expert who will dwell in detail about it. So for me, just to highlight few that, it is a patented process of extraction of collagen, which retains the triple helix structure, which retains the epitopes, which are responsible for generating oral tolerance, which is what is responsible for generating the T regulator cell as a response of T regulator cells as a response for cartilage regeneration and reducing the inflammatory response. So if you see collagen in our market, we have different type of collagen, but not all collagen are same. The molecular structure of collagen determines its mechanism of action. Denaturation of type 2 collagen disrupts its molecular arrangement and weakens interaction with pertinent cells and molecules. So if you see various structural component, including cross-linking, collagen triple helix, and active epitopes, which are maintained in type 2 collagen, which is undenatured, native, insoluble, is what retains its organic structure and bioavailability, which is what is responsible for the anti-inflammatory response and the regenerative, or so to say, reducing the damage to the cartilage. So this is just a study highlighting that not all collagen are same. As the undenatured collagen, the structural integrity of the undenatured collagen is important to trigger the oral tolerance mechanism that promotes the new cartilage growth. So this is from a study wherein UC2 was compared with covalent native type 2 collagen, and it was seen that how the structural integrity of UC2 was intact versus native type 2 collagen, wherein the nitty-gritties, structural nitty-gritties were damaged, and hence the mechanism of action, the need for higher dose for the native collagen, type 2 collagen, versus that for UC2. So UC2, the dose required to elicit the joint benefit is far lesser as compared to the native collagen type 2. So this is just to introduce the Centrum joint and mobility. So this is a combination of UC2 collagen along with vitamin K2, MK7, with calcium, vitamin D, zinc, manganese, and cupric sulfate, with once daily dosing, with unique combination of clinically proven ingredient of UC2, vitamin K2, and minerals to support joint health and mobility. So we all know the role of vitamin K2, binaquinone 7, which helps calcium binding to bone and strengthening the bone structure, keeps calcium away from arteries, keeping the arteries away from the calcification, which is commonly associated with vitamin K. Recommended form of vitamin K because of its long half-life and because of its microencapsulated structure, which offers a higher bioavailability. Of course, not to highlight the role of zinc, manganese, and copper, which is other minerals which have an important role to play in joint mobility. So with that, may I invite Dr. Nancy for her talk.
Hit the highlights. Well, good evening, everyone, and thank you so much for coming out in the heavy rain. I was impressed by the heavy rain. Okay. I come from California where we have droughts and we have wildfires, so I was impressed by the rain. So tonight we're going to, I stand between you and a lovely evening of dinner, but let me spend some time talking about what I'll call UC2, undenatured collagen type 2. I'm going to take you a little bit on a journey as to how we got to using these compounds in arthritis and what we know today about how they help. Let's see. So, okay, let's try this. Okay. So let's start by talking about the management of osteoarthritis. Most of you in this room are fairly experienced, so I like to make this quote. If there's an illness for which people offer many remedies, you may be sure the particular illness is incurable. And indeed, I think we all have to agree right now, osteoarthritis is a bit incurable, and that's where we stand. However, many societies, including the American College of Rheumatology, of which I belong, have thought about the best way to manage pain in osteoarthritis of the knee. And I think before we go on tonight, let's just look at this a little bit and think about the non-pharmacologic approaches, which I'm sure you all do, having your patients lose weight and exercise. But then let's look at the next, line there, using acetaminophen, over-the-counter nonsteroidals or topical nonsteroidals, and nutritional supplements. We're using that before nonsteroidals, before COX-2s, before analgesics and opioids and surgery. That's where we are tonight. Okay. So I became interested in supplements many years ago when I was asked by Dr. Dan Clegg and colleagues to help them do a study to see if chondroitin and glucosamine could help patients with knee OA. This was a really tough study. It was funded by our National Institutes of Health, and we had many treatment groups, and the patients had to have painful osteoarthritis of the knee. Now, what I want to show you here is what happened compared to placebo, glucosamine, chondroitin sulfate, and glucosamine and chondroitin sulfate. None of those were different from placebo, not even Celebrex, meaning that this particular combination maybe wasn't helping inflammation or wasn't helping cartilage. So we stopped there for a while, and now we're going to take a deep dive into cartilage in another way to treat osteoarthritis pain. Cartilage, as shown here, a little simplified, is proteoglycans with collagen type 2, water, and other molecules that come together to make cartilage like a sponge. When you put weight on it, the water goes out, and when you take weight off it, the water comes in, and that works very well. Within cartilage is one type of cell, those chondrocytes. What do they do all day and all night? Well, these are very interesting cells. As a somewhat of a cell biologist, I can tell you the chondrocyte is unique. Why? It not only makes the matrix it sits in, but if it gets the right signals, it also degenerates it. So it's breaking it down and building it up all at the same time. And until we get disease that is balanced. What makes cartilage special? What makes it special is the collagens and the proteoglycans that have glue and then the sponge-like properties. Okay, so how do we get osteoarthritis? Well, it would take me a few days probably to go into all the science of it, but I think it's fair to say that at some point, the mechanical forces that we put, at least on the knee joint and the hip joint, result in overload. Some of the cartilage breaks down, and that cartilage, when it breaks down, that type 2 collagen sets up an inflammatory response. And when we get the inflammation, we have then destruction, further destruction of the cartilage. Okay. So in that inflammation are T cells. Now, real quick review. We have, this is a very simple way to think about T cells. You've got Th1 cells, which are pro-inflammatory, Th2, which are anti-inflammatory, and Tregs, which actually are also really anti-inflammatory. And if you look here at my, wish I had a pointer. If you look here at my slide, you'll see IL-4, and that's anti-inflammatory, and IL-10 and TGF-beta, which is also anti-inflammatory. And that's important because those are the modulating cytokines that we're going to talk about. So what's the mechanism of action of UC2, our undenatured type 2 collagen? Well, this is a proposed mechanism. And I think as I show you data, you will probably come to the conclusion that this is most likely what happens. You take the undenatured collagen, it gets absorbed, goes through the lymphoid system in the gut to the mesenteric lymph nodes, and the Treg cells get involved. And you've got both increase in inhibitors of cytokines, IL-10, and pro-inflammatory cytokine. Oh, is that going to work? Okay. So when you make those Tregs, they both cause inhibitory cytokines, IL-10, which is going to stop inflammation, reduce the pro-inflammatory cytokines, and over time, reduce pain and inflammation. That's our mechanism of action of UC2 oral consumption. How do we know this? We know this from some studies that we did in the laboratory. And this study was done a little while ago, but we gave oral, undenatured, type 2 collagen to a rat model of osteoarthritis. What did we see? Now the slide gets a little busy, but if you can see, this was a pretty good animal design where we took rats, we induced an injury into the meniscus, which causes the cartilage to degenerate. We treated the animals 7 days a week for 8 weeks. And then we looked at how much weight they could put on the joint, the X-ray and the histology. What did we find? You see over here that this is placebo. And with UC2, the animals could put more weight on their joint. If you looked at the histology compared to the vehicle control, the UC2 had less cartilage destruction. And if you look at the bone around the joint, you see also that that was somewhat preserved. That was an important study because that led the way to then the clinical studies that I will show you. Now, let's talk a little bit about what is UC2, undenatured collagen type 2. It's
So a very good evening to everybody. So since this was an online meeting and it was delayed from Calcutta because of rain and whatever, so we have to manage both the things. So that presentation is going on. We'll proceed with our.
Can I keep going? Okay, sorry, I didn't know where that was coming from. Okay, let's look for a minute at this collagen classification. What is UC2? By processing, it's undenatured, it's native. What type of collagen? Type 2, that's the type that's in the cartilage. And the source for UC2 is animal. Okay, now let's go along. What are the differences? You've got differences in that you've got UC2 undenatured type 2 collagen. You've got an intact structure. It appears to be recognized by the body. And as I've shown, you get some oral tolerance, or I will show you that. The denatured type 2 collagen, the structure's destroyed. It's not native. It's not recognized by the body. And to date, we don't know that there have ever been any tolerance studies. Now, I can say that because I'm now going to give you some clinical evidence. A long time ago, when I was still a young person in rheumatology, a very important study came out of Harvard. How do I know it was important? Because it was published in the journal Science. And anything that's important gets put in the journal Science. What did these investigators do? As I will show you, they treated rheumatoid arthritis patients with active disease. They took 60 of these severe rheumatoids. All of them stopped their immunosuppressive agents, which at that time was methotrexate and Imuran, and they were randomized for 3 months to placebo or oral undenatured chicken collagen type 2 at 0.1 milligram per day for 1 month, and then increased it to 0.5 milligram a day for 2 months. And if you look over at the slide, you'll see that these are 50 to 55-year-old patients. They'd had disease for 10 years. They were on prednisone and immunosuppressive agents before this study. They were really sick. What happened? Well, what happened was kind of interesting and surprising. If you look at here at the baseline, look at the UCC versus placebo. At the end of the 3 months, the number of joints that were swollen went down. The number of tender joints went down. Morning stiffness went from almost 3 hours to less than an hour. And the patients thought that their disease was better, and sedimentation rate, which you all know is our very cheap lab test for inflammation, was 40 when they started UCC and went down to 1.7. This stuff worked, okay? It really worked. And I believe today that we'd actually be using this more in rheumatoid arthritis, but the biologics came along and that was that. Okay. Now I'm going to switch to the treatment of musculoskeletal pain and osteoarthritis. And before I do, I want to make a point. A point is, a number of years ago, I came to India to talk to you, and there'd probably only been about 3 studies outside of India with undenatured collagen 2. That's not so anymore. There have been many, and I'm going to show you some of that data. If you look across the number of studies, they've been done in healthy subjects and osteoarthritic subjects. They're randomized, double-blind controlled. They've compared to glucosamine and chondroitin, which has always been a question. And there have been about over 2,000 human subjects that have been studied from ages 20 to 80 in 8 countries. So I think there's a pretty reasonable database that supports the use of this medication. Now, let's take a look at the studies. This one may not get many of you excited in the room, but if you go to the gym and you see young people around the age of 40 complaining of knee pain from over-exercising, this may be an important study for them. This study was about 55 people who were around the age of 45 who did not have osteoarthritis but had knee discomfort from over-exercising. And they were randomized to take UCII or placebo for actually 150 days. And if you look carefully at the slide, you'll see what's interesting is that UCII did not really separate from placebo until you got to about 30 days. And from 30 days on out, you see you got more and more efficacy. The other thing that was important is the outcome measures that were used. When the study subjects went up and down stairs, the time it took after that exercise to recover from the knee pain was much less as they went out to 90 and 120 days, which isn't necessarily a measure we do with arthritis patients, but definitely something that people that don't have osteoarthritis and exercise a lot, that's what they want to know. And then when you looked at the time it took to do, the joint pain came when they were climbing stairs, it took longer in the UC2 group. But again, make my point, it wasn't different at 30 and it started to get different at 60 days. So patients have to be willing to take this for a while. Okay, let's leave the exercise and let's move on to more severe disease and the studies in osteoarthritis patients. One of the first studies done here in India was actually done by one of my colleagues at UC Davis, or he helped out, Siva Rachatari. They just looked at the safety and efficacy of denatured type 2 collagen in a small clinical proof of concept clinical trial. It was small. The number of subjects was 25 in each group. They're about 60 years old. Again, mostly female, but most of them had moderate to severe osteoarthritis. And then what they saw in this study, which was beginning to be very interesting, is they saw again, as the patients took the medication or the study subjects took the medication, there was not a lot of difference very early in, say, the first 30 days. But as they went out, there was more improvement in the undenatured type 2 collagen group. And that led to a larger study, a study that I participated in terms of data analysis, is where we looked in India at the efficacy and safety of UC2 in modulating osteoarthritis symptoms. And this was a randomized double-blind placebo-controlled study against glucosamine and chondroitin. What happened in this study? As I mentioned, there were 3 groups of patients. The subjects were 186 enrolled. We looked at their WOMAC, which is pain, function, and joint stiffness out to 180 days. We looked at mean pain scales, and these patients had osteoarthritis. Uh-oh. And here, what you can see is that, again, let's see if I can get this right. Again, when you started to look at placebo and the knee pain versus glucosamine and UC2, not much change at 30 days. But as you continued to 60 and on out, the placebo and glucosamine they all improved, but the UC2 improved a lot more and was significantly different. So if you can get patients to be patient and continue the UC2, I think that there's a lot of data now to support some efficacy. Now, we've talked about India. What about another part of the world? What about Latinos? What about in Brazil? Another study was done with undenatured type 2 collagen. And again, it was for patients with NEOA. And they randomized them to UC2 or no UC2, placebo. There were 100 or so patients, 60 to 80 years of age. And they looked at outcome measures, including SF12 and WOMAC, and they went out for 3 months or 90 days. Again, this data is very compelling. When you looked at visual analog pain scale and you got out to 90 days compared to baseline, there was a lot less pain in the UC2 group. When you looked at the change in this SF12, which is kind of a how are you doing in life, you can see that their lives were much better after being on UC2 for 3 months. And last but not least, WOMAC, a measure of pain, joint stiffness, and function. It also went in the right direction. It improved more on UC2 than placebo. So I know these are a lot of studies, but I want to just go over one more that is very interesting. It's a study where you compared either UC2 to glucosamine and chondroitin, which people still do, even though we don't have really strong studies to support it. What's very interesting about this study is the outcome measures. And when they looked out at 90 and 180 days, and you looked at pain parameters, you can see if you look at the orange versus the red, that there was less pain in the UC2 group compared to glucosamine and chondroitin with just about every activity. And stiffness was significantly down, and functionality was much improved. So I think that that was a good study to show that across multiple domains, you get some improvement. And then there's been some concern if there's the ethnic groups, if ethnic diversity is important at all in terms of who responds to this therapy. A small study here of 100 patients, Asian patients, looking at UC2 versus placebo, Asia being China, India, and other Asian countries, looking out across over 90 days. You can see again, across all ethnic groups compared to placebo, there's a nice response with UC2. So I think I've shown you more studies than I did when I was here before. A lot of work's been done. How do I put this all together? I think UC2, undenatured type 2 collagen, you give it once daily. Again, the proposed mechanism of action is through activating the Treg cells. You get reduction in the inflammatory cytokines and anti-inflammatory effects in the joints. It reduces pain, joint stiffness, improves function, and it looks to work in patients with mild to moderate NEOA or just knee pain. And different ethnic groups appear to respond, and there's not a safety signal. So that's what I can say today in 2025 about UC2. Thank you for your attention. Okay. Now, my group.
May I invite the panel, esteemed panel, to please come on the dais. We'll take question and answer from the audience, and I suppose we have few from online as well, from locations joining. Mics. Yeah, mics. Can you please bring the mics, please? So maybe we'll begin with questions from the audience. So please feel free to raise your hand and we'll bring the mic to you so that you can ask any questions that you would have.
Yes, please.
Hello, check. My question is UCII effective in carpometacarpal osteoarthritis?
Is this undenatured type collagen type 2 peptide is effective in carpometacarpal osteoarthrosis?
I believe if the question is the UC2 the same as the collagen in the joint, is that the question? Okay. I don't think it's been studied in like with randomized controlled trials. However, I would believe that it would be helpful. Helpful because the pain in carpal metacarpal osteoarthritis results from the same pathway, inflammation and pathway of OA and other joints. So yes, I think that would be a very worthwhile treatment for those patients.
I think it was.
Do you guys agree?
To be very honestly, if you ask me, we do. We do in the sense, like, if you have a rheumatic arthritis patients, they do have carpometacarpal osteoarthritis and involvement. And when you are giving a combined therapy of DMRD along with UC2, we do it some of the cases, as it has been discussed in IORA, we are doing this. So we can see a lot of good effects, like things are better. But to be very honest, just giving it and working on the carpometacarpal joints, no studies has come in. So
I would say that that's actually one of the weaknesses we have in studying osteoarthritis. I was just at a meeting on Tuesdays. A company wants to look at knee OA, and we're saying, well, find out about, record the other joints. Well, we don't want to do that. So that hurts us. So we have to be our own investigators and collect the data.
Okay.
Thank you very much, ma'am.
Devashish.
Yep. Osteoarthritis can be of two types. Maybe primary or secondary. If the secondary is there, will it be the same kind of treatment you advise?
Good question.
Secondary. So is it helpful for
Yeah,
secondary
yeah, no,
osteoarthritis?
I got it.
Is it your question?
That's a very good question. Would UC2 work in primary or secondary? The answer to that is no matter how one gets to joint degeneration, I think that the mechanisms that UC2 activates and works would probably work just as well. But like anything, the things the studies tell me is that patients really need to take it for about 3 or 4 months before they actually see, a maximal effect. So depending on the severity of it, I
Yeah.
would say I would try it. These guys. got
Thank
it.
you, ma'am.
Nancy, I think he was trying to point out that secondary osteoarthritis, your alignments are not in line, so they are disturbed. So is that works in that way? Devashish, to answer you, the mechanical part of that, which is in the secondary osteoarthritis, that's a different issue that can be taken care by many methods. But the inflammatory part of this arthritis, the treatment pathway is the same, and it's going to act as in primary as in secondary.
Whether
Am I right? Am I right?
whether it is primary or secondary, the treatment part, medical treatment part, I'm not going far for operative treatments, whether you should include disease modifying agent with this UC2, whatever it is, or not.
I think the medical piece of it, the inflammation and pain, I think UC2 can be tried. But, you know, if they have a torn ACL and, or meniscus or something that's making their joint unstable, UC2 is not going to help them.
That's fine. The question is, as you are an authority in rheumatology, so people are asking that if some patient is having rheumatic arthritis and he or she is
Oh.
on DMRD, to advocate this drug along with that
Ah.
to an
Okay.
addendum for that.
I apologize. I think I missed that rheumatoid piece.
It's all right.
Well, okay, well, that's a very good question. When I reviewed the data that I showed everyone tonight, I asked myself, well, why didn't we keep studying this? I think it would be helpful to patients with rheumatoid arthritis, and I think it's worth trying. And it might be additive, if not synergistic, with the biologic agents that we use today. I think that's a study that needs to be done.
Thank you very much, ma'am.
I'm sorry I had trouble with it, but I think I finally got it. Thank you, Collins.
Actually, to make your life easier, what is seen incidentally, almost there is all a secondary osteoarthritis. There is I think there are eminent medical faculties are also there. We can see, listen from them also. They may be dealing with much more
But
osteoarthritis.
there is a distinct
Okay.
diversity of primary and secondary
Just
osteoarthritis.
the practical check of view. So almost in our clinical practice, what we see in nowadays, it is almost all are secondary osteoarthritis. And in most of the literatures, they are mentioning that are basically they're dealing with the secondary osteoarthritis. This is one. This is a consensus. There are several reports. Second consensus is, as Nancy is rightly mentioned, there are two pathways. One is mechanical, another is inflammatory. Sometimes the rheumatoid arthritis, as I'm going to your point, rheumatoid arthritis, they have presented with the same picture of osteoarthritis. So what is the role of disease modifying? Exactly. Now my take is, now there is a mixture of this rheumatoid and osteoarthritis symptoms. Now there is a definite immunological role of pathways behind this sort of cartilage destruction. So cartilage is the ultimate victim of wherever the disease, rheumatoid or the osteoarthritis. So there is a definite role of this DMRD, that is disease modifying drug. In rheumatoid, there's a mixture of rheumatoid osteoarthritis, and also in the sole secondary osteoarthritis also. Now there is a question. Now the work is going on whether this DMRD can be used in a simple secondary osteoarthritis without evidence of rheumatoid activities. Now that is a Pandora's box. I think Dr. Nancy will highlight, and also our medical faculties are already there. They can also. Now there are two views. Now the DMRD. If we use in a sole case of osteoarthritis, now what should be the dose? Now if it is the positive, rheumatoid factor positive on all the tissue factors positive case, diagnosed case, they have to go, there is no questions that we have to give the full dose of the first line of drug, that is a methotrexate and the folic acid. Now there are work is going on. If it is a all factors negative, but there is all symptoms of the rheumatoid or rheumatic features along with the osteoarthritis, what should be the ideal dose? Now there are two theories. If the methotrexate is used in its full dose, 110 to 50 milligram once a week, that will block the dihydrofolase reductase. That is required in positive cases, that is factor positive cases. But if it is a negative, seronegative rheumatoid, all the symptoms are there, very small dose, even in a small frequent interval, 2.5 milligram alternate days, along with folic acid on the next day, that will block basically the ATIC enzyme instead of the dihydrofolate reductase. That will preserve the energy expenditure, that will preserve the energy depot or the anti-inflammatory pathway, and that will help in symptomatic relief in osteoarthritis. So that is thank you for your question. So that is the new thinking it is going on. So even in a secondary sole feature of secondary osteoarthritis, which is feature of rheumatoid, symptoms of rheumatoid like rest pain relief by activity with waxing and waning of symptoms, morning stiffness, as Nancy rightly mentioned, in this case, definite role of DMRD with a modified dose.
Yeah,
Because,
in fact, talking about this is opening up of too many Pandora's box. Like Kiran is sitting beside me. Like there are studies now which is saying that low back ache, around 50% of the low back ache is due to spondyloarthropathy, which have an facet joint arthropathy and a rheumatic variant involved in the low back pain. Kiran, your opinions regarding this. So that's a very pertinent point for treating a low back pain. Every low back pain we treat it like normal low back pain is not that. You need to ask certain questions. How I think let Kiran take it over.
I also want to talk something on UC2. So we are talking on UC2 this evening. So what is the mechanism of UC2? So that's the first we have to know. So it's a purely on immunological basis. It's a UC2 is given parural. So it's taken up by the Peyer's patches in the small intestine, and it's modular is taken up by the T cells, and it sends signals. So which inhibits these enzymes which destroy the type 2 cartilage in the joints. So the for the first question, so for anywhere any destruction of the cartilage, any osteoarthritis, so this should work. And there is also study or UC2 used in RA. Nancy has shown that slide. We have missed it. So she has shown that in the slide that there is a study, a randomized study on RA patients withdrawing all the DMRDs, and there was a very good result. So there was shown. And what Dr. Mukherjee was telling, that nowadays, we have a very senior person, Professor S.S. Jha in Patna. So he is the proponent of this theory very much, and he is using the normal DMRDs which we use in rheumatoid arthritis. He is using this in which we call a primary or secondary osteoarthritis of knee, and he is telling that he is getting good results.
Thank you for this. Any questions? Yes, I think there are several questions. Like this drug is very useful in mild to moderate osteoarthritis.
Sir, we have actually 4 sites or locations which are waiting for their turn to ask questions. So we'll invite one by one. So you can see them in the screen. So we'll go location 1 and invite question.
I would rather request location 1 to come on air and identify yourself and please ask the question.
So may I call upon Bangalore location to please ask their questions? Please go ahead.
Good evening, everybody. Thank you, Mrs. Dr. Nancy, for giving us a good overview of your product UC2. So, listening to your talk, I could understand that UC2 works very well with osteoarthritis in the elderly. But you also told that you tried it on the group between 40 to 50, where they were athletes or gymnasts, going to the gym, getting the knee pain. So they also had some benefits of UC2. So in this regard, I would like to ask, is it also possible to give it to even younger athletes who are as a supplement to try to get the cartilage stronger? Do you think so, or?
Yeah, that's a great question. I think so. I think the data really tells us that across the joint. Okay, I have to talk louder. Okay. I think that's a great suggestion. I think what the data is telling us is that this supplement or this UC2 has an anti-inflammatory effect. And that's going to help whether it's knee pain from overuse, knee pain from osteoarthritis, and potentially also knee pain or back pain, or maybe as in addition to rheumatoid arthritis, to add it as a supplement. I think we need to harness what we know about the mechanism and see where it can be useful across musculoskeletal syndromes and disease. It's a good question.
One more question from Bangalore. This is Dr. Bharat here. There have been UC2s which we have been using for the past decade. How Centrum UC2 is different from the already available UC2s?
Bharat, your question is, Bharat Raju, hi, how are you?
Hi, Amit, how are you?
Your question is pertaining to specifically UC2 or in general about UC? Centrum UC2 is Centrum UC2 on in versus general UC2.
Yeah, that's
So maybe I'll just clarify. So UC2 is an acronym patented by the innovator, which is called Lonza. So when you say UC2, that is patented. The other, acronym or other terminology would be undenatured collagen type 2 or collagen type 2.
No,
that would be the generic.
No, the question is how your product is different from other and superior than other. That's what Bharat wants to know.
So
am I right, Bharat?
Yes, that's right.
So the study that you just showed, Dr. Lane, in terms of how UC2 Lonza is different from undenatured collagen type 2.
Come again, please.
Well, it's basically that it's type 2 collagen is from animal and it's intact. It's not broken down. And that probably is some of the reason that we can get the efficacy from it that we don't see from other types of collagen.
So yeah, so maybe just I'll also add here. So the mechanism of action for UC2 is because of its intact triple helix structure. And that is the process of extraction of collagen from the animal source. So if you use heat, for example, or chemicals that would destroy the native structure, then the antigenicity is lost. So the whole mechanism of action is based on the antigenicity. So if the extraction changes the structure because it's a protein, then the protein as you take as a supplement will get destroyed in the stomach because of the HCl, and hence there will be no antigenic effect and no kind of interleukin T regulator cells coming into picture, etc. So retaining the structure is the most important nuance here.
What I believe, Raju, what he is saying, that this is more stable than other one, so that it works in the pairs patches that inhibits in turn for destructive enzymes of the cartilage. But he claims that this is more stable of an compound, right?
Compared to the others, yeah.
Can we have another question?
Any more question from Bangalore before we move on to Varanasi?
Yeah.
Any more question from Bangalore, please?
Yeah, one more I would like to ask. We have, the UC2, what you are telling. Can it be used in combination, like along with other anti-osteoarthritic medicines like hyaluronic acid or glucosamines? But it's quite prevalent in our country. Can we combine?
Yeah, okay. I think it can be used in combination. The studies to date have not done randomized controlled trials of the combination, but the mechanism of action is probably significantly different. So, it could be tried.
Okay.
No harm in trying, because in India, luckily we have the power to use combination therapy. So we can take advantage of the other, drugs also. So can we go to now the city of the
Yeah,
Banaras?
so thank you so much, Bangalore. So we move on to Varanasi.
Thank you, Bangalore, to be
Thank
so
you,
much
thank you.
proactive. Thank you.
We inviting questions from Varanasi. Please feel free to ask your questions now. Yeah, please go ahead. You will need to unmute yourself and please go ahead and ask your questions. Varanasi.
Varanasi, Dr. Gautam Bhattacharya is there. Gautam Chakraborty is there. No.
Okay, so if there are no questions from Varanasi, maybe we move on to Baroda. Baroda, please feel free to ask any questions to our esteemed panel here. Meanwhile, if there are any questions from the audience sitting here, since we are inviting question, you can also feel free. and
I have
ask.
one comment regarding the last question asked from Bangalore.
Sure, sir.
So regarding the combination drugs. So all the other drugs which are commonly combined for treatment of this osteoarthritis are chondroitin or glucosamine. So all these are anabolic. Even the collagen, other collagens, that is the denatured collagens, they are also anabolic. But only one combination which is used with UC2, that is the aflapine. So that only has a pharmacological action. So that is anti-inflammatory, that acts truly via LOX pathways, and that is the only second drug which has definitive pharmacological action. All the other drugs which are commonly combined, so these are all anabolic drugs only. So I think those there is evidence level of using those drugs also very poor. But nowadays, which these drugs are UC2 is coming with combination with other minerals, that's a different thing. But regarding as a DMOD, disease modifying osteoarthritis drugs, so the UC2 and aflapine, those have the definitive pharmacological actions. Other don't have such pharmacological action, and the evidence level also poor.
To add a point with Kiran, Centrum itself is a very big combination. It has Brucella serrata, which is aflapine, and it has इस पे आपका 5 जो है बताएं जनाब. Magnesium,
Yeah.
which is a trace element, zinc, and
Copper, calcium, and vitamin D.
calcium and vitamin D. So these becomes 5 goals in one shot. So they take care of all these things, and these rare elements nowadays, they says that it has a big role to play in well-being of life. What do you think? What do you think, Nancy? The rare elements gives a
Yeah, the rare elements probably cause vitality, I guess, the sort of, yeah.
This copper probably acts on the MMP.
Sorry, sir.
The copper usually, I think it's probably acts on MMP.
Yes.
Matrix metabolic. So that is that destroys the cartilage. So that acts against MMP.
So meanwhile, we're still inviting questions. I have few, generic questions that I get. So just to, involve you in inviting your views. So, sir, what has been your experience of, say, UC2 use? Do you use it? And how do you place in the therapy in the management of osteoarthritis?
For that, I have one question to Nancy. So it's my question. So the doses you use for UC2 is only 40 milligram per day. So if we use say twice a day or 80 milligram per day or 120 milligram per day?
I think that the dose you use is less important, whether it's twice a day or once a day. I think what the studies have shown is that you need to keep taking it. You need to take it for 6 months, 4 to 6 months. That's when you're going to see, I mean, you'll start based on the data. your patient should start to tell you that they're feeling significantly better at about 60 days. But from the data that we've seen, it looks like it continues to improve, maxing out at about 180 days. So it would not be the right supplement to give a patient that's inpatient, okay? It's a supplement to give somebody who's willing to use it, be consistent, use it for a while, and looks like that's when the benefits come. But that makes a lot of sense if you look at the mechanism. You've got to get the medication through the gut. The Tregs have got to get to the different lymph nodes and out to the joint. That's not instantaneous. So, 3 to 4 months, patients should start to feel better on it. And over the next few months, whether you take it once a day or twice a day, I don't think is so important. At least I don't know the pharmacokinetics in that way that would make a difference. Yeah, it's a great question.
So maybe, sir, I'll
Thank you very much, ma'am.
add here on, sir, just 1 minute. So we recommend it to be used as once daily, and 40 mg is the dose on which the studies are done, and that remains the dose across the geographies. So once daily, 40 mg. Yes, sir.
Ma'am, this is a very simple question. Whether chondroitin sulfate is actually needed for this kind of formulations, because so far my knowledge goes, chondroitin sulfate is not basically absorbed in the human body.
Well, we think it is. I mean, the glucosamine literature and the chondroitin literature is challenging to get through. There's lots of studies. Some of them seem to show efficacy. But one of the things that I found always lacking in that data is a true mechanism of action. So you can take it alone, you can take it together. And I have patients that come to me and say, what about this glucosamine sulfate, chondroitin sulfate? I want to take it. I said, okay, take it for a couple of months and then stop taking it and see if your symptoms come back. And so, but basically we don't have as good of data that I'm aware of in the, from the GI tract through the,
Yeah, it cannot be absorbed in the GI tract. It's being proved. A lot of proof is there that it's not being.
it's not being absorbed.
yeah.
So then does it change the microbiome? I don't know.
Yeah.
That's been a question that's never been answered.
Yeah.
It's a good question though, but it's never been answered.
Okay, so any last question between you all and the
Great
dinner?
audience.
Yes. Yes.
Okay.
Can we restart it again or not?
Take it.
I was actually I was going to ask the question to everybody, because we are using UC2 for almost 4 to 5 years minimum. So everybody have the experience of using UC2. I have not faced any side effect, but that was my question to everybody here. Have you faced any side effect after using the UC2? So that's the question you have asked, sir.
And maybe I'll just add to the point. See, the current formulation that we have is available actually as a food supplement, as a nutraceutical. So it's not a drug per se. And because, drugs are regulated by DCGI because of their safety profile, because that's the primary criteria of differentiating. So it is available as a food supplement for daily consumption. And maybe as sir is inviting, if you have used any UC2 or any combination, what has been your experience in terms of the safety profile, if you want to add?
So you can.
How long, as Dr. Nancy, maybe Dr. Nancy, if you would like to, highlight in terms of how long would you recommend UC2 be used?
Well, I think that how I use it in my practice and how the studies show is I ask people to take it if they're going to start it, to stay on it for 6 months, 180 days. About that time is when we get either maximal effect or no effect 180 days.
So 6 months is what. And so the data suggests, so the longest study available is around that duration.
Generally, in this part of the country, as you have asked, we use around 3 months. Am I right? Minimum to see a result, and maximum, if you ask me, I have used for a year. Patients are there with for a year, but as someone says, side effect, barely, hardly any side effect. Did you see? Barely you could see any side effects.
But I think that you do.
Sir,
you do
did you go for any blood reports
No.
after 3 months or 6
No,
months?
no, I
Blood
never.
tests? Well, in rheumatoid arthritis, it changed the sedimentation
Yes,
rate.
yes.
In osteoarthritis or musculoskeletal pains, usually the sedimentation rate or the CRP is not elevated. So you really pretty much need to ask the patients to monitor their symptoms. And usually I agree with these guys, 90 days is kind of a thumbs up. And then if they're getting a response, it'll continue to improve over a period of time. Yeah.
That's
In
true.
my experience,
As she told earlier also, the ESR, you or him told that 31 to 17. So that is a quite enterprising,
Yeah,
but
that
that
was
is,
that was in rheumatoid. though.
yeah, that was in rheumatoid. But in normal osteoarthritis, I think barely there is anything which has to be done. Did you correct it? No? What do you think? In normal osteoarthritis?
Okay, I think the kids are.
I don't think there is a no blood parameters is required with this because
So from our side also, there is no recommendation in terms of following up with any investigation to check on the safety profile. And just to let you know, as an organization and as the innovator, which is Lonza, which has this molecule across different geographies, on the safety profile, we have not received any signal, so to say, in terms of the safety signal. So generally well tolerated across geographies. Okay, if there are no further questions before we thank our panel, maybe invite Vivek to say a token of thanks as floral token of thanks to our esteemed panel.
We thank Centrum for giving this platform, and we really thank all the delegates who has participated. Without you, this wouldn't be a success.
Dr. Vivek.
Yes, and thank you for being a wonderful
Yes, sir.
audience. Thank you.
2 minutes on conclusion. Sure, sir. Welcome.
So there is a very good evening. We actually we have discussed about there's a role of these drugs. I think there are some confusion. Just I conclude. So basically, this is under the groups of systematically active, slow-acting drugs against osteoarthritis in the mnemonic CISA-DOA. So basically, the osteoarthrosis is a degenerative disease. Once it addition is inflammation, it is osteoarthritis. So once the osteoarthritis comes in mild to moderate cases, there is a definite role of these anti-immunogenic drugs. This is basically it is not absorbed as you have mentioned rightly. The most it acts on pars patches by stimulating the T regulatory cells by TG10 and the different anti-inflammatory medications for anti-inflammation. So I think this is there's a slowly acting drug, so should be continued for at least 3 months, maybe continued for 6 months to 1 year. There's a part of the multi-modality treatment of osteoarthritis, and there's a definite role in mild to moderate osteoarthritis. Thank you.
Thank you, sir. Thank you. So maybe invite Vivek to pass on the token of thanks to Dr. Pal first. There are more bouquets coming your way, so. Dr. Kumar, please. Dr. Mukherjee, Dr. Lane,
Okay, thank you. Thank you for coming.
So thank you, everyone. Thank you, this wonderful delegate sitting and listening, spending this evening with us. The dinner is now served. May I invite all of you to join us for the dinner. Thank you so much.